Good evening, respected members. Welcome to, on behalf of IAP Bangalore, I welcome all of you to this wonderful Bangalore Connect program, great Bangalore Connect program. Today we have a very important topic for discussion. Before we begin the session, I would request to welcome our President, Dr. Raghunath CN sir, past President, Dr. Sumita Nayak Madam, and stars for today, Dr. Devendra Mishra sir and Dr. Mahesh Kamate sir, and our Doyen, Dr. S. Srinivas sir, Dr. Sanjeev Joshi sir, our President-elect Dr. Sarath Chand sir, and all others who have joined today, especially Dr. Nandi sir, who is in a program. He could not talk to us. So I welcome you all. Before we begin, I request Dr. Raghunath sir to give his opening remarks.
Thank you, Sunil, and I welcome all the IAPians for this wonderful session. This has been our fifth consecutive IAP Connect, Great Connect, and this is our brainchild of IAP and Dr. Sunita and the previous many past presidents have bought it since COVID, and we are going on continuing with it. This headache is always a headache for most of the clinicians. I mean, whenever we meet a patient with headache, they say, if you go, most of our patients are Kannada, as we are speaking. Sir, talenavu, sir, magange talenavu. This talenavu becomes a pain for all of us because we don't take a proper history to know whether it's a primary headache or a secondary headache, how to go about it, what are the red flags, when to do a scan for these headache. And I think all these things will be dispelled by our great speaker, Dr. Devendra Mishra sir, who is also an editor of IEP journal, who was, and Dr. Mahesh Kamte is there. He has been teaching all of us every day through the WhatsApp group. Sir, thank you very much for teaching us, bringing out new cases and showing and helping us to diagnose more number of patients which we... Hemalata madam, excuse me, Hemalata madam, can you switch off your speaker? Can you mute yourself? Yeah. So Kamte sir has been not only a teacher for his own students, he has been teaching whole of Karnataka, and hope today's session will go fantastic because of Dr. Kamte and one more star speaker, Dr. Devendra Mishra. Sir, this is a brainchild of Nandish, our convener. Unfortunately, Dr. Nandish has gone out for some function and is not able to attend this session. Both Dr. Basaraj and Nandish are missing on this session for this particular program. Last 4 programs, they were there. And I don't want to stand between Devendra Mishra sir's lecture and keep on going on and talking about things which may not be of much interest to all of you. So here I hand over the mic to Dr. Mahesh Kamte ji. Over to you, sir.
Yes, sir. Before Dr. Mahesh Kamte, sir, I'll just introduce Dr. Mahesh Kamte, sir. He is our chief guest for today. Sir is a professor and head of pediatric neurology at Jain Medical College, Belagavi, Karnataka. Area of interest are epilepsy, genetic cerebral palsy, neurometabolic disorders, neuroimmunology, vitamin deficiency, and pediatric stroke. Sir has got more than 125 publications in PubMed indexed journals. He is one among the first batch of DMs from AIMS New Delhi, and he has got Best Young Scientist Award of KL University for the year 2013, and he was Secretary of AOCN India 23 to 25. Over to you, sir.
Thank you, sir. I thank all the IAPians, IAP Bangalore branch members for the invitation and attending today's meeting. I have a present duty to introduce our speaker, Dr. Devendra Mishra, sir. Dr. Devendra Mishra is currently Director Professor, Department of Pediatrics and Honorary Faculty, Department of Medical Education at MAMC, that is Maulana Azhar Medical College, New Delhi. He's in charge of pediatric neurology clinic at Loknayak Hospital, New Delhi. He has got connection with Karnataka. He's done his MBBS from GMC Ballari and Gandhi Medical College, Bhopal. So he has a Karnataka connection. He has done his MD Pediatrics from Medical College Rewa in Madhya Pradesh. And he has done his advanced course in medical education in the year 2016 from MC Nodal Center, CMC Ludhiana. Sir is trained in radiology in AIMS New Delhi between the year 2002 to 2004. This is the year when I joined DM in AIMS, and I'm really very helpful to Dr. Mishra sir for helping me in settling on Institute of Medical Science. That was totally a new place for me, and he really helped me in settling in AIMS New Delhi. So, very grateful to you, sir. He has worked at Indraprastha Hospital, RML Hospital, New Delhi, Chacha Nehru Bala Chikiৎসালয় Hospital, New Delhi, and he also worked with England Trust International. He is a he has got a fellowship of IAP in the year 2017, and previously he was editor-in-chief of Indian Pediatrics Journal, executive editor of Indian Pediatric Case Reports, the associate editor for MAMC Journal of Medical Sciences. He is a member of ICMR project review committees, Board of Research Studies of AMU, BHU, IEC, CNBC, Delhi. He has participated in many funded research projects and has got a lot of publications in both PubMed, international and national journals. With this brief introduction, I hand over the stage to Dr. Mishra, sir. Looking forward to hear from you.
Thank you, Mahesh, for such a detailed introduction. You forgot I have another Bangalore connection. My in-laws are also from Bangalore. My wife is from Bangalore. So two connections, one from with VIMS Bellary and another from Bangalore. So I will start sharing my screen and start the session.
Yes, sir.
So is the screen visible? I will
Yes, sir.
start
Yes,
it.
sir. It's visible.
So what I wanted to talk today was headache in children, basics and beyond. So many of our uh, viewers may be already be aware of some of the basics. So they just rest assured that last 4 or 5 slides will go beyond the basics, what is currently happening in the field of headache medicine and in pediatric headache medicine in particular. So I would just jump in. Pediatric headache, what we would be covering is how common it is. And in addition to common, is it important to know about it? What are the common causes? Uh, then the more important causes of pediatric headache, what is migraine and what are its triggers? What is stress headache? What are the red flags? Dr. Raghu talked before also. What are the red flags and how to manage? And then what are the recent advances? So pediatric headache, as he was already saying, that it is not uncommon. In the West, 23 to 50%, nearly, let's say, 1/3 of the pediatric population has had headache once in the last 1 year. In India, this number among adolescent school children is 57%. In the two studies which studied this problem over the last 3-4 decades. Migraine, West, the incidence is 3 to 23% among children and starts increasing with age, especially after the adolescence. Among Indian studies, school children, 17 to 25% have been reported to have migraine headaches. Most of these are surveys, and some studies have tried to confirm the diagnosis after the survey. So we know that let's say up to 1/3 to 1/4 of the children would be suffering some kind of headache, and some of them may come to you for management, and we need to tease out whether this is a more serious ominous problem underlying the headache or it is one of the primary headaches. So how do we go about that? Important thing is that headache is a significant cause of disability. It is one among the top 10 causes of disability associated life years in children also. A recent systematic review and meta-analysis of primary headache epidemiology in children found out among the 8 to 18, 48 studies, and the pooled prevalence of primary headache was 11% for migraine among this whole pediatric population and 17% for tension type headache. So it's quite common. So this is disability due to various disorder from global burden of disease study. This shows the years lived with disability per lakh population due to headache. So I won't go into much details because this is not pediatric data. This is overall population data. What it shows is that the more developed countries have higher prevalence of uh, years lost or disability due to headache as compared to the more underdeveloped countries. But it has been seen that over the years, the middle income and lower income countries are catching up in with relation to the disability due to headache. Probably this is because of the stress of the modern lifestyle. We do not know, but that is one trend which is being seen over the years. So, what is the clinical profile? So very few studies have really seen pediatric headache in India. Most of them are hospital based, one or two are school based. But almost all will agree that migraine is the most common cause of primary headaches in children. Uh, Hospital-based studies of recurrent headache. So this is a important difference when you are reading a study on pediatric headache, that if you do a study in the community, in the school, you will find that almost 60% of the patients will be having tension type headache or some secondary cause of headache, and very 35% will be having migraine. However, if you come to a hospital-based studies, large majority up to two-third or 60% will be migraines, because migraines are the more severe headaches, and because of the severity, most of such patients would be attending hospitals. Whereas tension type headache or stress headache is more common, but because it's mild, so hospital treatment is not received. But when you see it in the population or in the school studies, that is more common. How common are eye problems leading to headache? So most of us feel that eye problems are an important cause of headache, but most of the pediatric studies you will find less than 5% patients had eye problems as a cause of headache, and despite the cure of eye problems by providing relevant spectacles, or still the headache persisted. So these are more of a comorbidities rather than the real cause. ENT problems are rarely a cause for recurrent headache. And another thing which I will not revisit is the imaging, because imaging in a primary headache never ever leads you to a causative cause, a causative finding. Always you may find some uh, minor abnormality, but that is usually not the cause of the headache. Pediatric headache is different. Why is it different? Let's see. Uh, Common causes of pediatric headache: among the primary headaches will be migraine and tension type. Among the secondary headache is unrecognized hypertension. I can't really stress upon it too much that hypertension, one of the earliest sign would be headache. And if you do not recognize it, take blood pressure in a patient, you will miss it and it will keep on occurring. And later on, with end organ damage or malignant hypertension, the same patient may present. So for each patient, we expect that all children have at least the measurement of their blood pressure once during their consultation. But even if that is not being done, at least any patient coming with headache, you do take blood pressure once. ENT, ophthalmological and dental reasons may be the cause. And the most ominous, which we are really worried about in any patient of headache, is the presence of a space occupying lesion. So majority of pediatric studies have shown that eye problems are not a common cause of headache, but this one study with showed which was done in the ophthalmology services showed that among the patients 190 around 19 200 something patients of pediatric headache which attended the ophthalmology department, 63% had refractive errors and 20% had migraine. So contrary to most other studies, they showed that a large number of headache was due to eye problems. But I feel the this may be because of these parents must be aware of or must have had some inkling of the eye problems, and that's why due to a headache they visited an ophthalmology department rather than a pediatric or general pediatric department or a pediatric neurology department. That is the only explanation, because this is only single study which is showing a results different from the most of the trend for pediatric headache. But whatever this means, any child with persistent or long-standing headache, you definitely want to rule out refractive errors, which may, even if they are not the cause, may be contributing to the severity. So we go to the causes. First one, we just address migraine. So what is migraine? So migraine in children is a headache which is bilateral, throbbing, and lasts 2 to 72 hours, is disabling in nature, is recurrent, is associated with nausea and or vomiting, and also associated with photophobia and phonophobia. The definition, this is the standard definition by International Classification of Childhood of Headache Disorders, the third version. So what is important is that migraine in children is different from adults. The major differences are most of the migraine in adults is unilateral, but in pediatrics it is frequently bilateral. The duration recommended is to make a diagnosis of migraine only if it is at least 4 hours and up to maximum of 72 hours. But for pediatrics, the headaches are usually last for lesser time, and therefore the definition has been changed to 2 to 72 hours. So headache should last at least 2 hours to be classified for migraine. And the third one is that the photophobia and phonophobia may not be told by the child or the parents. It has to be inferred from the history by the behavior of the child during the episode. So the child will not like to sit in the light, or even if there is a light in the room or it's a daytime and sunlight is there, he will try to sleep by covering his head or and eyes with his hands, or use a bed sheet to cover his head so that he does not have to uh, be exposed to light. So these are the three major differences in the definition in pediatric migraine as compared to adults. The If you talk to the most of the practitioners or even to the most of the sufferers, they will agree that it is the longest duration and most disabling headache they suffer. So even in kids, when they have mixed headache, one due to maybe tension type and another due to migraine, they will always say that at the start of headache, I am able to appreciate whether I'm going to get migraine or tension type headache, because at the start only I know that it is going to be very severe, because it is throbbing and it is suddenly occurs in the whole of my head. So that is one thing you can always check with the child also. The other group, major group, is stress or tension type headache. So it is not due to tension. It was previously said to be stress headache, and now it is labeled as tension type headache. So it is completely different from migraine. It is headband distribution. It is usually not severe or excessively disabling. Children are able to attend their school or even to complete their homework despite having headache. It has a bilateral location. It is non-throbbing and non-pulsating. It is not aggravated by routine physical activity. Migraine is a disabling headache. There is a physical disability associated with migraine, and the child is not able to play or do homework or sit in the class due to the headache, whereas in tension type headache, these activities are possible. There is no nausea or vomiting. Anorexia may occur with tension type, but no nausea or vomiting. So these are the things which differentiate the tension type headache from the migraine headache. So this is the distribution of the migraine headache in a headband distribution, and sometimes extending to neck and the back, which never ever happens with migraine. If you ask triggers for migraine among children, up to 40% will tell about stress as a trigger for their migraine. But stress as a cause of tension type headaches has not been proven ever. But if you're asking about triggers, like we did a study on this thing, asking triggers from a list of triggers, we asked about triggers of migraine in children, and almost half had said that stress, whether related to exams or related to homework or related to scolding by parents. And this was around 10 years back. Young kids with headache. So headache starts quite early. It may occur quite early, up to 1 or 2 years of age also. So taking history and evaluating younger kids with headache, what are the issues? So first is insufficient past pain experience. So these children have not had suffered much pain due to any reasons except for probably immunization injections, and therefore they are not able to describe their pain, quality of pain, severity of pain, and therefore you need to help them, provide them the appropriate words to describe their headache type and severity. History is colored by parental experience. So many times with the recurrent headache, and the parents will come, he eats too much chow mein or too much momos, or he uses phones too much, plays video games, always plays in the sun. So these type of complaints from parents are there. So they will color their history according to that rather than the actual history of headache. Acceptance of diagnosis. Once you make a primary headache diagnosis, again parents are reluctant to accept. इतने छोटे बच्चे, why such a small kid has migraine, this is a lifelong disease, what will happen to him, and things like that, or they will stop coming to you. And charting, headache charting is quite difficult. Asking kids to do that and ensuring that they fill the chart completely. Some of the younger kids who are unable to write, their elder sibling or parents have to fill the chart for them. And sometimes the severity and type are not entered correctly. So red flag, how do we know that the headache which is there is not a severe disorder or space occupying lesion or intracranial bleed, and it is likely to be a non-serious disorder? There are certain uh, signs or red flag signs. One is the systematic signs and symptoms. If there is fever, there is weight loss, associated secondary conditions like HIV, tuberculosis, another malignancy, then you should be really very inquisitive about diagnosing the cause of headache using all the investigations at your disposal. Neurological signs, along with headache, a good neurological examination is essential. And if you find a recent change in behavior, recent change in sensorium, even a single seizure anytime in association with the start of the headache disorder, you should think about some other uh, cause which is intracranial rather than primary headache disorder. Onset. How is the onset? Is sudden, abrupt, or split? This I will address again. But such a sudden, abrupt, or split second is a subarachnoid bleed usually, or a concussion, and therefore you should be uh, sure that you rule out these. Presence of papilledema or other signs of raised ICT, again red flag, and a previous headache history. So if somebody is having the first severe headache, you should be looking for other causes rather than migraine. Migraine usually starts slowly, one episode which is low grade, then another episode slightly, and gradually builds up to a recurrent headache of roughly same quality. So if it is a first severe headache or there is a sudden change in character of headache from what were happening previously, then you should look for a secondary cause. So these are the smooth red flag signs. These are commonly quoted in most neurology books for ruling out a underlying secondary severe headache, severe disease which may be causing headache. So while taking history, headache chart is very important. This is the English version. We also have a Hindi version in the local language and an Urdu version also. We have made this. So this is a headache chart. What it should include? The time, so headache duration. So you want the time when headache started, the time when the headache stopped, and the duration in minutes or hours. What was the severity? What was the disability? Disability is 1 to 4, which is a non-standard classification, but most books are mentioning this. Uh, what are the associated symptoms like photophobia, phonophobia, nausea, vomiting? Any aggravating factors so that you come to know of any triggers so that you can avoid them. And uh, the severity of the headache in the form of a visual analog score. So VAS score is a visual analog score which you can use in children 6 years and more. And for younger kids, you can use a FACES score, which has at least 5 faces, 0 to 10. If you want to combine with the VA score, then 10 faces are made in the visual faces score, and 0 is a smiling face, and then 10 is a face where the uh, patient appears to be in distress. So the younger kids can tell what they are feeling, whereas for older kids, you want them to score. 0 is no pain, and 10 is unbearable pain or the most severe pain they have ever felt in their life. So that's what we tell. For some kids, what is good is that you can tell them that the better you give score to your marks, just like the same way as your teacher gives you marks out of 10, you have to score your headache out of 10. So they understand, most of school going kids will understand that and are able to give the score to the severity of it. So we have got this table for 7 days, and we have got 6 such tables pasted on a single A4 sheet, typed on a single A4 sheet. So we give one sheet for 6 weeks. So our usual follow-up frequency is 6 weekly. So they will come after 6 weeks. So the whole thing is filled up. So if they do not have a headache on a Monday, they will just cross it. Whichever day they have, they can fill. So out of all the slides in this session, probably this one is the most important in teasing out the cause of headache. This is the Rothner's classification, and proud to say that, and Dr. Mahesh will also feel proud that he was a pediatric neurologist who gave this classification long time back, when probably pediatric neurology was not a very well described branch also. And this is the temporal patterns in the history of headache. So if somebody comes to you with recurrent headaches, whether child or adult, these are the patterns which are suggested. Symptom severity. So A is distinct episodes of severe headache which start suddenly, go to a maximum, then subside. Then there is a pain-free period. Then another such episode. So this is typically for migraine. If there are low-grade headaches, but they keep on occurring, between the headaches, the patient is not normal, not headache-free, then this is a chronic tension type headache. But if the headaches are between the episodes, the patient is normal, but the headache severity is not too much and disability is not too much, this is intermittent tension type headache. But if there is a headache which gradually starts and over a short period increases in severity and keeps on increasing in severity, this is an ominous headache, and we have to rule out an intracranial cause or another severe secondary cause. And then there may be mixed version where tension type and headache, migraine add on, and sometimes in adults even medication overuse headache will add on. So this will just have a few acute episodes, baseline chronic episodes. So this is very difficult. The mixed type of headache is very difficult to really make a diagnosis of. So this temporal pattern, if we apply, we would be able to really uh, do good with making a appropriate diagnosis in the child presenting with headache. So PET-MIDAS is another tool which is available in most Indian languages, free to use. It just has 6 easy questions and takes 5 minutes or more. Uh, this is a migraine disability assessment scale specifically made for pediatric patients. Just ask how many days of school you missed, how many days of play you missed because of your headache, how many times you had to go to doctor for headache. So this just scores the disability due to headache, and you can follow up this score to know whether the child is responding to your treatment or worsening, and you need to hike up the treatment you are giving. So once you are somewhere in the diagnostic journey of the headache and you have made a diagnosis, one way or the other, of one of the primary headache disorders, mostly migraine, how do we go about it? So unless red flag signs are there and you have taken a blood pressure and good history and examination, there no investigations are needed. If you feel like if the child doesn't have a yearly medical exam in school and has never had his visual acuity and orthoptic evaluation done, then you may get an eye exam done. Otherwise, eye or ENT routine examinations are not required. Ocular findings, if you find anything, mostly they will be a comorbidity rather than a uh, rather than the cause of headache. Identification and avoidance of trigger is important. Good history and a good headache diary helps in avoiding triggers and identifying them. You need to remember, just somebody says he eats momo and gets headache, he eats pizza and gets headache, or he eats Chinese food because of MSG or something like these, he gets headache. That is not true. For a trigger to cause headache, it should cause headache every time the child is being exposed to it. If the child is getting headache after eating it for multiple times and only once he gets the headache, then unlikely this thing is a trigger. Regular sleep and meals. This we tell every child and even adults also, but it is important. It is one of the founding requirement from lifestyle changes for controlling headache, especially migraine, that there should be regular sleep and regular meal times and not missing breakfasts. This is important. So adults know, adults take charge of their disease. Adult doctors also know that the patient is the suffering from disease and it is his beliefs and which needs to be addressed during treatment. But pediatricians sometimes forget this, and you need to give the charge of the uh, disease to the child. The child should be involved in management. Child should decide how much, whether you need to go for prophylaxis or you need to just treat acutely. Both headache diary and the drug usage. These can be used as a tool to empower the child so that the child understands that this is the disorder and I can control this disorder. Headache diary, the child gets a feel that he can tell about the headache so that the doctor can make a diagnosis. Drug usage. So many children get their headaches during their school hours because most children are spending almost more than 50% of their waking hours in the school. So many times they are going to get their migraine headache in school. So I always advise the parents to give one dose of the pain acute management, whatever drug I have prescribed, to the child in the geometry box so that the child knows whenever the headache is starting, I have to take the drug. This way, the child gets some control over the headache management. This, so, what management options we have? Uh, Environmental and lifestyle changes are the cornerstone. Dietary factors, if you are able to identify dietary factor, I think less than 10% we are able to identify. But if you want to, we run a specialized headache clinic, and in that headache clinic also less than 10% have any dietary triggers for headache. So if you can identify them, avoid them, then definitely headache will be much controlled. Headache diary that needs to be uh, done, and even after the diagnosis has been made, still you need to continue with that headache diary so that you can chart the response to therapy. And other biobehavioral treatment is also an adjunct. I will address that later also. Pharmacologically, we have acute treatments and prophylactic treatments. So just getting this thing out of the way, non-pharmacological interventions, a network meta-analysis recent in 2021 only studied more all these previous studies on these, and what they found was that out of all these things, that is psychological treatment, biofeedback, self-administered treatments, mindful medication, placebos, all combined were better than what? The comparator was better than being put on a waiting list for treatment. So their comparator group was those patients who had been put on a waiting list to see the doctor for treatment, and the other group was receiving these, so the other group was better. However, when they studied each of the individual things like placebo, psychological placebo, or self-administered treatment, or meditation, or biofeedback, these none of these was significantly better than placebo. So so most of these are, you may find, I have seen studies published in some Indian journals where yoga has been shown to have 85% response rate uh, to of migraine in children also. But most studies which have been published do not support such findings. So environmental and lifestyle changes uh, are a precipitant. People have identified that up to 20% of younger kids less than 7 years and older kids and adolescents up to 45% will have some precipitant in their lifestyle or in their immediate environment, and these need to be addressed. Patient education should I tell them about regular sleep, exercise, and meals, identifying and avoiding triggers, and what is this disorder, so that they know that they have to manage this disorder, and probably this disorder is a lifelong disorder which will have a waxing waning course. Behavioral strategies, cognitive behavioral therapy, and biofeedback and relaxation had initially shown some effect. If you have the option and the facilities, you may try in the patients, but usually does not work. Again, physiological triggers, bright lights, TV screens, all these, if they are precipitating in somebody, then it is good. Otherwise, somebody is seeing TV or mobile and you just want to shut it off because the patients are pushing it and are unable to do that and they are pushing you to say that. Don't do that, because probably this may cause stress and increase the headache rather than reducing it. So you just ensure that if each of the headache episodes are getting precipitated by these, then definitely these need to be avoided. Otherwise, as per WHO guidelines, you can permit them using these screens and all. Dietary factors, McDonald, long older studies, just because of the name I am quoting these studies. This is not from the McDonald restaurant, this was a different person. And they also found around 15%, as I was saying, our clinic 10% we find that 15% may have issues with something tyramine containing things like dairy products, cheese, etc., or MSG containing like Chinese food, or nitrate containing like sausage, salami, or hot dogs. So you can avoid the identified triggers. Acute attack at home, what do you want to do? Lie in a quiet or dark room, damp clothes over forehead, reassurance. Sleep, if the child can go to sleep, it is the most potent anti-migraine drug. All Almost all patients who have migraine, it will subside after going to sleep. Although once you have the episode and it has progressed a bit, going to sleep is very difficult. Painkillers, paracetamol, brufen, and naproxen can be used. Most of the uh, studies or multicentric studies have shown naproxen is better than paracetamol and ibuprofen. And whereas paracetamol and ibuprofen are equal, some say they are same as placebos, but we find that majority of the patients will respond to that. Antiemetics, many patients with migraine will have vomiting at the start of their headache, and it would be difficult to give them oral painkillers. So either we can use some intranasal preparation, or if they are unable to afford that, then you give a mouth dissolving antiemetic like a mouth dissolving tablet of uh, domperidone or ondansetron, and after some time you give the painkiller, the analgesic. Take medicines early in the course of it. As the attack of migraine progresses, it causes gastroparesis because it is a neurovasogenic condition and gastroparesis occurs. And therefore, once you take the medicine after that, it is not absorbed. It is stuck in the stomach itself. Therefore, it is always said that at the first sign of start of a migraine headache, they have to take the medicines, that is the acute treatment medication, the analgesic. Uh, and believe me, howsoever times I may say, many people won't believe me, but just believe me that any kid, even small kids like 6-year-old kids, they also tell us that we know that when the headache is starting, we know whether it is going to be the migraine headache or the other type of low grade headache. In the hospital, you have to decide. Usually, if the patient has come to the hospital, we usually prefer IM or a IV route. Otherwise, oral drugs can be given, paracetamol or ibuprofen, or even triptans. Nausea and vomiting won't respond. For that, you have to give antiemetics. They also don't work very well. There is not much evidence that combination analgesics are better. Although for some patients who have vomiting at the beginning, paracetamol plus metoclopramide combination is there that sometimes works. And about triptans, we will talk later. So we have oral triptans like sumatriptan and naproxen. We have a nasal spray, zolmitriptan. These are the AGs for which they are approved. There are some alternate newer triptans also. If you have status migrainosus that is not responding to any drug, then IV valproate at 10 milligram per kg, or prochlorperazine, that is Stemetil, or even metoclopramide are effective. Alternate triptans are elmotriptan, which can be given orally. Rizatriptan can be given orally. Rizatriptan is the only triptan which is approved for children 6 to 18 years also. Otherwise, most triptans are available for children more than 12 years. So rizatriptan is available. Dose is 5 mg for those who are less than 40 kgs and 10 mg for those who are older. Sumatriptan nasal spray has not shown efficacy in pediatric patients, but it is available. There are newer triptan nasal sprays, which we will talk just now. So usually it is said that if the child has 3 significant attacks per month, significant means what I would say is either 3 school absences or 3 attacks during which they could not carry out their routine activities, that is, could not complete out their homework, or could not go out to play, or could not participate in family activities, or could not go to school. So 3 such severe attacks per month, if they are happening, this is an indication for starting prophylaxis. Less than that, you are like 2, 3 minor attacks a month, or 1 or 2 minor attacks and 1 severe attack per month. You can manage with acute treatment. You will see, once you make a correct diagnosis of migraine and start the acute management, gradually the stress due to undiagnosed disease and recurrent attacks reduces, and the child's episodes of migraine also reduce. For prophylaxis, if other than greater than 3 attacks, if the frequency of headaches is increasing, or the attacks are not severe but they do not respond to acute treatment, again that is an indication for prophylaxis. Usually we try oral drugs, and remember that any migraine prophylaxis you have to give for at least 6 to 12 weeks. That is around 3 months before you plan to we label it as ineffective. And in case it is effective, then you give it for around 6 months and then try a break and see that whether migraine has been controlled. So this control issue. So migraine in pediatric age group with good acute episode management or with good prophylaxis, you can give a trial. Many times you will find that a child with 8 years old with severe migraine, if you give a prophylactic medication of 6 to 8 months and then you taper off the medication, the child remains to headache free for 2 or 3 years. And then again the migraine attacks start and then you can manage again. So that possibility is there in pediatric patients, which is usually not there in the adult patient. So we should try for that, that give a break from prophylactic drugs if migraine remains controlled. Drugs available, propranolol we use a lot, and no previously used a lot, and but no, most of the literature says it is not more effective than placebo, but we find it to be quite effective. The other one is valproate, topiramate, flunarizine. Again, not much literature people like to use, but we have used these three: propranolol, valproate, and topiramate. All the three are effective. You can give a trial usually, and if not effective in 12 weeks, then you want to change to another one. And some newer drugs are there, which we will just see. So before going on to the newer developments in pediatric headaches, which is another, I think, 5, 7 minutes. I will conclude this presentation that till now, that it is a common problem which we should not miss. Diagnosis is primarily clinical. Do not go in for neuroimaging or major investigations. Lifestyle management and trigger avoidance is the cornerstone. Upon that, good management of the migraine headache or tension type with acute analgesics, and prophylaxis is very effective in children, and when started you should try to give a break after 6 to 8 months. We usually try and give that this break from prophylaxis at the time of summer vacations. This is because that is the least stressed period for the child, and that is the time when probably he is unlikely to get a breakthrough headache, and we try to give this during the summer vacations rather than giving a break in the prophylactic medicine sometime prior to exams, or which is a high stress period, and even a single episode may spoil the examination performance. So what's new in headache? So I will just talk about what's new in headache medicine per se, and just point out what is important in pediatrics headache. So the relationship of tablets and headache is very long, very goes back a long time. So this is a Sumerian tablet, which was made in 2500 BC, so third millennium BC, before Christian era. In this, migraine in a patient has been described in this tablet, where it is some name has been given, which means some external power taking control of the head. So it was known that so long back, although it was treated with not with medicines, with different other things, chants and everything. And now we have come to this tablet. So this is an electronic tablet, and this is used for two purposes nowadays in headache medicine. One is electronic headache diaries. So these diaries are with the patient on the patient's tab, and patient can enter whenever they get headache, its severity, triggers, medications, and everything, so that a summary is available to the doctor when the doctor sees the patient next. And in between, you can also think about this in the form of tablets, which we used to take for acute management of the migraine or tension type headache, and which is now changed to newer versions of nasal medication. Nasal triptans are available now for the management and overcoming the issue of nausea and vomiting associated with migraine. Coming to electronic headache diaries. So two types of electronic headache diaries, multiple are available. Some are paid, some are non-paid. The two which we have tried to use are free. One is Migraine Buddy and the other one is Headache. So the Migraine Buddy uh, charts the episodes, number of episodes, duration, severity, and easily downloadable from Google. The other one is Head App. Head App additionally has the advantage that you can enter the triggers also. So what you ate today, what you exposure to screen, everything you can enter. So if there is a trend over, let's say some time, that every time your headache is there, there is a associated trigger, the app will pick it up. And the other thing is medications. So you can enter your medications also in this app. So it provides a chart and to the doctor about the medication usage also, the disability also, and the triggers also. So either of these are free to download, although both are in English. So only those kids who are slightly older and know English are able to use and are willing to use can use this. So this leads to some gamification in the management of headache, and those who use it like it. Medications wise, what is new? So for acute management, previously we had simple analgesics and then sumatriptan, zolmitriptan, and rizatriptan. Rizatriptan was the one approved for pediatric patients, and sumatriptan subcutaneous injections were available, antiemetics and valproate. Now newer drugs are G-pens. We will just see how they work. And then ditans, lesmeditan, which are 5-HT1 agonist. And prophylactically, previously we had propanolol, amitriptyline. Amitriptyline is more useful in tension type headache, anti-epileptic like Topex and valproate. And then we had calcium channel blockers like flunarizine and cinnarizine. Newer drugs, again, CGRP, calcitonin gene-related peptide, monoclonal antibodies, GPENTs, again, some GPENT like rimegepant is effective both for acute management and prophylaxis. And then we have botulinum toxin. So this slide shows the mechanism of action of these newer drugs. So primarily there is a migraine trigger, whatever it may be, stress, hormone, sensory input, or something which is unidentified. It causes trigeminal nerve activation, which uh, causes a cortical spreading depression, leading to a calcitonin gene-related peptide release. This is the molecule which is responsible for all pain-related further pain-related activities. CGRP binds to receptors and there is vasodilation and pain. So the new class of drug, this is Ditans. Lesmeditan is the one drug which has been received approval. It is 5-HT1 agonist. It prevents the trigeminal cervical this combination nociceptive firing. So pain discharge does not start. and therefore it reduces CGRP release. Then botulinum toxin, it blocks the presynaptic release of CGRP. Monoclonal antibodies, they will bind to the CGRP ligand and prevent it to receptor activation. GPANTs and Erenumab, which is again a monoclonal antibody, they will physically block the CGRP receptor, or the antibody will block the receptor, so that the manifestation of vasodilation and pain are addressed. Again, then intranasal triptans. Intranasal triptans, currently sumatriptan intranasal has come. Previously, what used to happen was that the nasal sprays, most of the drug is deposited in the anterior nostrils itself and does not reach the mucosa, most of the mucosa where it is going to be absorbed. A new Optinose has come. Optinose is a breath activated spray. So what happens? It has two openings. One goes into the nostril and the other goes into the mouth, and you exhale in the machine, and as you exhale, that pressure pushes the drug into the nostril. So the glottis remains closed at this time, so the drug doesn't go into the throat and goes into the posterior nostril and the nasopharyngeal area and is absorbed. However, it is not approved for children less than 18 years yet, and also not available in India. So, but still trials are going. This is likely to become more effective, shown to be more effective than the nasal spray. Among the G-pants, Rimegepant, Ubrogepant, and Zavegepant, all three are available. Zavegepant intranasal spray is now available. Nothing great to differentiate these three. Rimegepant is one which is approved for pediatric usage. We have talked about Ditans. Lasmiditan, again, Lasmiditan is not approved for pediatric age group, so we are not going to discuss it, but it is 5-HT1 blocker. Among the monoclonal antibodies and G-PANTs, both are very costly drugs. Among these, Erenumab, Galacanizumab, Epitinizumab, and Fremenuzumab are the drugs. Fremenuzumab is which is approved for more than 6 years of age. It binds CGRP peptide. The dose is 120 milligrams subcutaneously, but prices are, I think, more than 50,000 rupees or so for per injection. We haven't used, being in a government sector, we do not have the availability of this drug. Probably if somebody of the viewers and Dr. Mahesh has used, they will later on tell us about it. Other among the prophylactic G-PANTs, Rimegepant and Atogepant both are available, approved for those above 12 years of age. Botulinum toxin is used in adults, not approved for kids below 18 years. It is used for chronic migraine primarily, multiple side effects, and you can't really use it repeatedly. Newer things is neuromodulation devices. These either stimulate the vagal nerve, or they sometimes stimulate another nerve to modulate the pain response. Two of these, which are approved for children, I will show. One is the Nerivio. Nerivio connects to the smartphone app to provide a 45 minutes of controlled electrical stimulation to some nerve fibers in the upper arm, activating conditional pain modulation pathway that inhibits nociception. So this signaling prevents blocks the pain pathways, and this signal surpasses the pain signal. So therefore, the pain is controlled. It has to be used for 45 minutes. There are 30. It can be only used 30 times and then needs to be recharged. Cost is around, oh no. So no, Nervio is 12 times. So 12 to 14 times it is used and then needs to be recharged. And each charge costs around 18,000 rupees. So instrument is, I think, 5,000, and then 18,000 for every 12 usage. So this can be used at home. The app is in your smartphone, and then they give you an instrument, and that controls the stimulation. The other neuromodulation device is a non-invasive vagal nerve stimulator. So you apply it on the neck near the vagus, and gentle electrical stimulation is given. This is different from the VNS, which is given for epilepsy. It is approved for 12 plus children. Its bursts are 2-minute bursts, and it is shown to be effective also for prophylaxis. So 2 minutes morning evening reduces the frequency of headaches also in migraine. Uh, it costs around 50,000 rupees in India. It has got 30 charges, again needs to be uh, recharged for 50,000 rupees. The other ones I have given the trade names. These are approved for adults only. They are used at different places in the neck or the face for stimulating the nerves. These are the protocols. So last slide, I think. Uh, so if you really want to take home some messages from this presentation, I will just want to tell not nothing much hi-fi. Basically, measure blood pressure for every child, and especially those come with headache. Where BP is not contraindicated in younger kids, you need to take it in everybody. Talk to the patient alone. So parents will come, headache from 3 months, only 2 episodes, yeah, headache for 6 months, only 5 episodes, and you talk to the kid and clearly ask, so he will also say 5 episodes. But you ask, beta, which class? Some they say, I'm in third class. So did you used to get headache in second class also? Yes, I used to get headache. With vomiting? Yes, with vomiting. So if you ask the child, you get to know low grade headache, which they didn't tell their parents were also happening. So you have to talk to the parents, definitely. They will give you the best history. But talk to the patient too. And if this slightly older kid, definitely talk to them alone also. You may get to know some stressors also. One patient we have diagnosed with physical abuse just because of taking history of the headache, and that too by a resident. I missed that, but the resident picked that history. Help the child in giving history. Help them in describing. So throbbing headache or pulsating headache. How does a child tell that when he has had never had such a headache? So we ask them whether there is something bursting inside or whether there is a machine which is running inside. So they will tell you that yes, something like that happens. So that is all from my side. And if you really want to manage these children, use the PED-MIDA scoring for disability and do use a headache diary, whether electronic or a printed. Thank you.
Thank you,
Thank
sir.
you. Thanks. Any questions?
Thank you, sir. That was a wonderful talk, you can say. I request Dr. Mahesh Kamate to take it further.
Yeah. It was a very comprehensive coverage of the topic, starting from the clinical part till the most recent advances in the available drugs produced in migraine. Sir, there is one question for you regarding can refractory error cause headache? How important is refractory error in headache treatment in children?
Can refractory error, I'll just put in my charger.
Yes, sir. Yes.
Can refractory error? So what we are talking about recurrent headache. So refractory error headache has many characteristics like more usually evening during school times, not happening on weekends or not happening during vacations. So most of the parents are able to identify. And nowadays, I think even government schools and even smaller schools have yearly medical examination where there is a eye checkup. So we rarely find. I started my headache clinic in 2005 and it is now 21 years and roughly we are getting 10%. We did a study in that it was 0%, but now I'm seeing in working in a setup where many of patients from very lower socioeconomic class come, so around 10% will have refractive errors, but out of those 10% also I think 70 60 70% the headache will not go even after using specs. So the primary headache is still there, this thing is only adding on to that.
Yes. It's actually, I feel it's more overhyped that everybody gets an ophthalmologist done before they come to us. But as I told, the nature of the headache will really tell us if there's any fatigue. It happens only while studying. Otherwise, it won't be there. So, very good coverage of topics. So actually, just wanted to make some points. We mentioned that to diagnose migraine, the criteria for migraine, we say that the headache should be of at least 2 hours. But in practice, when you see cases, children, when they say they have headache for about half an hour or for 20 minutes, 45 minutes, so we generally get stuck. Does it fit into migraine? But it's important to note that most of the children headache, they have headache and they go to sleep. They sleep for 1 to 2 hours. So the duration of sleep is also considered as a part of the duration of headache.
Yes.
Study the
Yeah.
headache for
So
50 minutes and sleep for 2 hours. We take it as 2.5 hours, not just 50 minutes of duration of headache.
Yes.
And the criteria for migraine, what we discussed that 5 criteria, all headache need not fulfill those 5 criteria. Even if a child fulfills, the child has about 20 headaches in a year, even if 2 or 3 headaches fulfill the criteria, they still get a level of migraine. It's not that all headaches should have the 5 characteristic points of to call as migraine. So
So I
majority
think,
of
yeah.
the
So
yes, yes.
five, I think they want a five headaches at least to really label migraine. But for kids, usually headache, younger the kid, the headache is migraine is usually not that well formed, and gradually as they become adolescent, it becomes well formed. So even if one or two are fulfilling that criteria, then you can label as probable migraine and start
Yes,
the appropriate treatment.
yes. One more thing is, many children's headaches do have scholastic issues also. Like many of them have hyperactivity, dyslexia. So it's important to note the underlying cause for this headache. So the underlying scholastic problem can come as headache. So it's a good practice to look at their marks cards or look at the notes. I usually ask them to get their notebooks next time they come to me for follow. We look at their writings, and there you can pick up an undiagnosed dyslexia or ADHD. And because of this child has scholarship issues, that leads to stress, and that can come out as a headache or tension headache. So the good practice to look at the books and look and ask them the school performance. That will give you many answers regarding what could be the probable underlying cause. If you treat the cause, then headache will automatically get under control.
Yes, definitely.
Any other questions from the audience? During seasons like rainy season and winter season, sinusitis is also an important cause of headache. If you have a child who comes to with daily headaches for last 2 to 3 weeks and no headache prior to that, and they may not complain of any cough cold and all. If you look at the throat, look at sinus point tenderness, that can be a cause of sinusitis presenting as new onset daily headache. And it's very common during winter season and rainy season. So that time before
So
we label them as tension headache, rule out cause common cause like sinusitis and treat that. Otherwise, unless they get label of migraine tension headache and they'll be put on long-term treatment. So these are 4 or 5
yes.
practical points I wanted to share.
Very important problem raised. ENT, acute ENT problems are important cause. So important issue is that the Rothner's classification is the thing. So one episode and then well period and then another episode needs to be there. Or so in this type of patients who have like sinusitis frequently, is that whenever they get respiratory illness or some, they will have headache which will last for some days and then it goes off and then again recurs. So or if acute headache, daily headache has come, then new onset. Definitely, it is a secondary cause rather than prime.
Okay, if there are no any questions, now I would like to request Dr. Srinivasan sir, doyen in the field of pediatrics, to give his comments. Dr. Srinivasan sir. Sir, you have to unmute.
Enjoyed thoroughly, and of course, so much of newer advances and monoclonal antibodies. So, anyhow, it's becoming very common, especially triggered by repeated, plays, electronic games, etc. So it precipitates. I think it is one of the precipitating factors. I don't know whether he will agree with that,
So
but
it's a lack of sleep, sir,
yeah,
because they spend a lot of time on the
especially
screen. That leads to
yeah,
lack of sleep. That comes out as headache.
yeah. Thank you. I enjoyed it thoroughly and
Thank you,
learned
sir.
a lot. Thank you.
Thank you,
Thank you,
sir.
sir.
There is one more question from Dr. C.N. Reddy, sir. What is the earliest stage of diagnosis of migraines, sir? Once you know.
Very nice question, sir. There are two issues. When, at what is the earliest stage when migraine occurs? And the other is when we can make a diagnosis. So there is no cutoff mentioned. So younger kids also, but non-verbal kids, it's difficult. People have made diagnosis even in children and babies less than 6 months retrospectively. So retrospectively, the baby had recurrent episodes of excessive crying for 6 to 7 hours and then it used to settle then again. So many of these things like recurrent abdominal, this
Colic,
many of the
infantile colics.
cyclical vomiting syndrome and all, these were previously told as pre-migraine disorders or younger kids. So these kids, when they became slightly older, then the diagnosis of migraine was established and people went back and said these episodes probably were also migraine. But I think that roughly 3 and a half would be the age when I would think of we get a good history, with a good or okayish history from the child also, that it is headache and not something else, which is usually. And you will see, sir, that most of the migraine in the younger kids has more autonomic and GIT manifestations. So more vomitings and nausea rather than more of headache per se. But definitely you can make a diagnosis at that time. But be very much aware that you are going to revisit your diagnosis if it is not responding to the simple analgesia.
Sir, one more question, sir is asking. Equivalent of migraine in children. Or migraine variants or something, sir. wants to know.
So, sir, probably these are linked to the migraine variants like cyclical vomiting syndrome, or previously benign paroxysmal vertigo was also known as a variant of this. So these are probably genetic disorders. So with some link to migraine, and as we are teasing out specific genes for these are getting separated out. So we have to make individual diagnosis for them, and only when they follow up and when the child becomes slightly older and converts into having migraine, then you can really label them as pre-migraine or uh, migraine in children, disorders which are predate migraine in children.
Wonderful, sir. If there are no any comments or questions, I would request Dr. Raghunath, sir, our president, to give his closing remarks. Dr. Raghunath, sir. Sir, unmute.
Thank you, Sunil. It was a wonderful session. Dr. All of us about the newer things in my brain.
Your voice is breaking.
And not to forget to check
Sir, your
blood
voice is
pressure
breaking.
for
You are
any
not clear,
child
sir.
with my
Voice
voice
is
is
breaking.
breaking, sir.
Video off mabadi, sir.
Okay. Can you hear me now?
Yes, sir. Now we can hear you, sir.
Okay. Can you hear me?
Yes, sir.
Yeah.
Yes, sir.
Okay. Sorry for that. I think we had a wonderful session of Dr. Devendra Mishra, sir. And important thing about the headache is very, very important. And the second thing is eye evaluation. Eye is not going to give you, your refractory errors are not going to cause headache. The other thing is you have to think of sinusitis and rule of the seasons like winter seasons, which we need to consider. So thank you very much, sir, Kamte sir, for your time and your sharing your knowledge throughout. And also thanks to the Dr. Devendra Mishra, sir, for coming here and spending his valuable time to, this evening.
Thank you, sir.
So thank
Thank
you,
you very
sir.
much
Thank you,
for giving
Dr.
me opportunity.
Srinivasan, sir. And thank you.
I have to thank you.
Yes, sir. Thank you to Dr. Sanjeev Joshi, sir,
Thank
who
you
is
all.
also joined.
Sir, I'll give
Always
vote
a
of
part of
thanks.
IIP, Bangalore and IIP. Yeah.
I'll give vote of thanks, sir.
Sorry?
So on behalf of IIP Bangalore, first and foremost, I would like to thank Raghunath sir, our president, who has been the driving force behind all these programs, academic activities we are conducting. I thank you, sir. And the stars for today, Dr. Devendra Mishra, sir, who made it from simple for pediatricians to complicated for postgraduates, you can say. Very thankful to you, sir. Dr. Mahesh Kamte, sir, has taken his time out of his busy practice sessions. Thank you, sir. We thank the Doyen, Dr. Srinivasan, sir, the uh, pediatric
I
neurologist
am a
and
student, not a
yes,
doyen.
yes. That is your simplicity, sir. Dr. Sanjeev Joshi, sir, for being in the program. I thank our EBs, Dr. Adarsh, Vice President, Dr. Sharat Chand, sir, President-elect, Dr. C.N. Reddy, sir, Dr. Raghu Gokhale, and all the other EB OBs and the uh, present today, who joined and learned a lot of new things, I think. I hope. Thank you. Thank you all. Good night, sir.
Thank
Good
you.
night, sir.
Right.
Good night, sir.
Good night.
Right. Good night.
Good night, sir. Good night.
Good
sir.
night, sir. Good night.
Good night, sir. Thank you, sir.
Good night. Good night.
Good night, sir. Good night.